to turn it over to Dr. Friscia, and he will start the presentation. Dr. Friscia, it's all yours, sir.
Thank you. Well, thanks for coming out this rainy afternoon. It's just starting to sprinkle as you're coming in, so I'm glad everyone made it. Glad you're coming out for this interesting topic. I've been at Eisenhower for over 30 years now, believe it or not, and been in this room for many meetings and lectures and things like that. But anyway, over my career in foot and ankle surgery, bunion surgery has really evolved. And it's kind of interesting because when I started, I do total ankle replacements, I do complex foot and ankle reconstructions, I do arthritis surgery. I still love the bigger cases and find them challenging. And I never thought I'd be, have this niche and focus on bunions. But over the years, bunions are extremely common, and we'll talk about that in a little bit. And it's been interesting that over my career, I've really seen the treatment evolve. That in the past, it was the surgeries we have. Well, we'll talk about more too, but there's lots of surgeries for bunions. The results weren't always reliable. And a lot of doctors just did not like doing bunion surgery, and the results were not as reliable as our other procedures. So in any case, it's kind of been exciting that over my career, I've really seen bunions evolve and their approach to bunions change, and it's been nice to see the improvement in outcomes, improvement in surgery. And the other area that I'm excited about is total ankle replacements, where we've really evolved to do something that when I started that was not being done at all in this country, and now it's really the gold standard for ankle arthritis. And at the end, you can have questions. I'm an orthopedic surgeon, and I specialize in foot and ankle surgery, and we can ask other topics too, but today concentration is on bunions. So as the title says, bunion surgery has finally evolved and changed, and I think we've learned enough over the years that the results and outcomes are much improved. And over my career, I've seen that with the evolution, years ago, there was a surgeon, Lapidus, who in the 1920s published an article which basically described a similar procedure. But the doctor I trained with, Dr. Ken Johnson, I did my fellowship years ago at the Mayo Clinic in Scottsdale when they first started the clinic in Scottsdale. Now, I think they call it the Mayo Clinic Arizona because it's expanded into Phoenix and they have a couple campuses. But in any case, it's a great facility. And he was one of the leaders in foot and ankle surgery back then. And I saw that there was mobility of the foot, that people develop a bunion, you bump here, but there's mobility at the midfoot. The foot has 28 bones and joints, and these joints, although they don't ordinarily move much, they're stability joints. The foot can widen through these. So we found that wrapping the foot, you could actually correct the wide foot and the bunion because there's enough movement here, and that was a component of instability. And that's kind of come around to really validate what we're doing now. So this was just an example of the preoperative wrapping of a foot that bunion deformity would narrow, and you could see that on X-ray without doing any surgery or any bony work. You had some improvement. This was actually years ago. I kind of had a little technique where I would not fuse any joints and simply release the joints and stabilize the base joint, with what was then an absorbable screw, and they could get good correction. And it's basically a similar concept and procedure, but this has come around to really be similar to what we're doing now, and so we've learned a lot. There's lots of bunion procedures, and that's why bunion surgery kind of has a bad name. There's over 100 different operations for bunions, and that was because in the past there was a certain failure rate, and not every procedure worked well. With some procedures where you just operate on the toe at the end, there's a risk of recurrence. If you did a cut the bone at the base, there's a risk of the bone traveling up and putting pressure on other joints in the foot and giving you calluses and things like that. The toe, the anatomy of the foot's pretty complex, and all the tendons to the toe insert on the toe, not on the metatarsal. So if there's ever any loss of balance, the poles are all on the toe, and the lever arms, pull it off into either what's called varus or valgus, out of position. So it's kind of very complex in that way. And then if you get pressure off the big toe joint, then suddenly your other metatarsals get pressure. And so I'm sure some people have calluses, and you have pressure under the metatarsal heads. As we all get older, the fat pad on the bottom of the foot specialized for pressure, and it atrophies a little bit, and you're at more risk of developing pain on the bottom of the foot. So as we all know, the foot's very important, and and these things are complex. So these subtle differences could cause complications. So there are, again, many procedures for bunions, and as I said, in the past, there was a high rate of the bunions coming back, of patients being dissatisfied. What we've discovered and really come to realize, that the bunion is not just a two-dimensional deformity; it's really three-dimensional. It's not just that the bump, it's not a bump that's growing. Bunion is a Latin word for turnip, I think, but it's not that you have this bump here growing. Sometimes from arthritis you get bumps, but that's different. But you don't. It's not from a growing bump. It's from instability at this joint, the base of the metatarsal, the base of this bone, and then it comes out and this gets prominent. And also it's rotating. So with a little instability in a rotation, the foot that widens and forms the bunion. So it's really, you have to correct the deformity in more than one plane and rotate the metatarsal, as it says. And so that's been over 10 years now, and again, the basic concept was around years ago, but it wasn't necessarily well accepted or as well understood. But about 10 years ago, with all the research and data, a company kind of latched onto this and realized, well, the procedure wasn't easy to do it reproducibly and make it and avoid complications, but they developed a technique and instruments to minimize shortening, make it reproducible, make it so that most surgeons could do it and effectively with a high rate of satisfaction. And so with certain jigs and devices and cutting blocks, just like with total joint replacement, we have guides and cutting blocks that help our anatomy and judgment. We're able to reproducibly correct the bunion. So again, I don't have to go through all this data, but there's so many studies showing there's a high recurrence rate and complications rate with many of the past bunion procedures. Some studies as high as 73% recurrence rate. That's totally unacceptable. And even 30% is way too high. I mean, we want procedures that 90% plus effective. I mean, you don't want to have to go back to surgery if you can avoid it, certainly. So as you can see, these X-rays just show the some different bunion procedures. Sometimes they cut the bone at the head, near the end of the bone. Sometimes you cut it at the base. But the basic concept is the deformity is coming from instability at the instability at the base here. It's not coming from the bump here. So we have to approach this, and the procedures that don't have a higher rate of recurrence. So, and as this X-ray shows, you can cut the metatarsal, but the metatarsal does not become a crooked bone. It's always a basically straight bone. And anytime we cut the bone to try to correct it, you're making the bone crooked. And so you're not approaching the problem. And so the key to the Lapidus procedure is that you have to restore the anatomy here. And this is the pathologic joint. And it's a stability joint, not a mobility joint. So stabilizing this, you don't lose motion. And even to this day, this is a procedure that's being done commonly now, so-called minimally invasive procedure, but it's very, as you can see, it's very unanatomic. The bone, it's not an easy procedure, and it doesn't have much advantage, and you still have this huge deformity here. But we'll look at some more of that in a minute. But anyway, the key is restoring a stable foot with a normal anatomy. So as I've said, the bunion is not just a bump that's growing. It's, when people come in, sometimes you say, well, can't you just shave off, just cut off that bump and I'll be good. Well, you can't do that because that bump is really half the joint. So you want to restore the joint. You want to restore the anatomy. And as I've said too, it's caused by the unstable joint, this what's called a tarsometatarsal joint, the joint at the base of the first metatarsal, which is really the pathologic joint that's rotating and moving. And that joint, in normal motion, that joint doesn't move much at all. Most of your motion in your foot obviously comes from your ankle, but also in the forefoot, it's the big toe joint. That's where the big toe joint is also the most common site of foot arthritis, another issue if you want to discuss that later. But but the big toe joint is the one that we want to preserve because that's where most of your movement occurs in your forefoot. So by stabilizing this unstable joint, you don't lose any function. In fact, people feel better because that instability, I think, bothers people to some extent, and you correct the deformity. And as this slide shows, it's a rotation where the metatarsal bone is rotating, and those two little dots there are, those are the so-called sesamoid bones. People always ask, well, on X-ray, well, what are these things? They're not floating on the bottom of your foot. They're in the flexor tendon. They help the lever arm to flex your toe, just like your kneecap is a bone that's in the middle of a muscle and tendon. It's in your quadriceps and patellar tendon, and it's increasing the lever arm to extend your knee. So those two sesamoid bones are in a tendon, and with a loss of the normal anatomy that they attach to the toe, not the metatarsal. So suddenly they're pulled off and they rotate and increase the deformity, as this slide kind of shows. And some of this is a little bit technical, but just trying to give you a sense of some of the philosophy behind this. So this is just an example of the 3 slides showing how those sesamoid bones, are rotated in different patients, and on X-ray, it's not that the sesamoids move straight over; they actually rotate. And the point is that these bunions have all bunions have some level of deformity, and it's from the first metatarsals deviated. It's not deformed, it's not crooked, it's not bent. It's rotating and moving, and that first tarsometatarsal joint is abnormal. And so this is the X-ray of basically a normal foot on the on I guess it's your right side, and on the other side is the bunion on the left side right here, and that's a bunion deformity of widening of the so-called intermetatarsal angle. There's some instability at this joint, and that's a moderate bunion. And there's some that are less severe and some that are worse, and there's different degrees of bunions, obviously. And they like the Leaning Tower of Pisa with an unstable foundation, the bone leans sideways. The foundation's not good. It's moving because of that pathologic joint, which is not stable. It's an anatomic problem, and people are predisposed to it. Bunions in the past, bunions, we thought a lot of bunions were caused by bad shoe wear and high heels, and that was thought, well, that's maybe why it seemed that women had more bunions than men wearing certain shoes. Obviously, nowadays shoes are more sensible. Not narrow, pointy shoes are not always in fashion, but it's not. But and obviously those shoes can cause an imbalance if you're wearing those all the time. But it's more anatomic or hereditary type thing that everyone knows. They say, "Oh, my mother had bunions. I have bunions," and men have bunions. In fact, some of the worst deformities I see are men that come in with bunions, and it's because I'm not shoe wear. It's because of heredity. It's family history and instability of that joint. So again, it's a three-dimensional problem. As the bone rotates, it elevates up. When it elevates up, that puts pressure on your other metatarsals. You can get stress fractures. As the toe moves, the big toe can press on the second toe. You can get hammer toes where the second or third toe right up, and the knuckle rubs in your shoes. I'm sure some of you have had those that can be very painful in shoe wear, difficult for shoe wear. Obviously, one thing about the desert, when it's not the winter, we can wear open shoes, so it's not as uncomfortable. But certainly in closed shoes, bunions and hammer toes can be very painful. And so in the past, the traditional two-dimensional bunion surgery just involved, cutting the bone and shifting it over and fixing it with two screws. This is an example of an older procedure. And this still could be done for mild deformities called a chevron osteotomy. It doesn't solve the cause of the problem. And over the years, it can recur because you have instability at the base. But this can last for a while and give some relief. And as it says, the bump is gone, but the bone, now the bone is crooked, but the joint's still unstable. And over the years, the bunion has a good chance of recurring with this procedure or any distal procedure nowadays. And so this is just an example of an X-ray. You can see the foot looks abnormal. The foot's wide. Those are significant bunions. And then this is a corrected bunion. This was a foot that looked like that before. And then with this with this Lapidus type procedure, we've stabilized this joint with cutting guides. We stabilize this joint, and with the plates and screws or staple plates, you stabilize this, and this bone fuses. You don't lose any function, and the toe stays straight. And you haven't cut the bone in the middle. You just remove this joint here. And so again, the key to it is that the natural anatomy is restored. It's the normal 3D alignment. And the toe rotates back to where it belongs, and there's less chance, and you get rid of the deformity, and you also lessen the chance of arthritis. Because over the years, if a bunion, like a tire that's not aligned, if you have a bunion and your big toe's off kilter, it can predispose that big toe to developing pain and arthritis in the future. So again, this procedure secures an unstable foundation with plates and screws, and it's designed for permanent correction. And I think the beauty of it is, as we'll talk about, the procedure is reproducible. You can weight bear early, much less chance of recurrence, and people feel better. And most patients come back for the second side. These are frequently bilateral because it's a hereditary type problem. So again, this is an example of a foot. This is a pre-op on one side and the post-op on one side. You can see how much straighter the one foot looks. It's, your shoes don't have to be as wide. You don't wear your shoes abnormally, and the joint's stable. And this is a lasting bunion correction. So again, as I've discussed, why the Lapidus procedure? It's you cut the bone, and you have these jigs that are able to correct the deformity, so you're able to plan for it. If before it was a harder procedure because you would try to make cuts and try to align it, and then you could take too much bone, and then that provides complications. So it was not a easy, simple, reproducible procedure. But now with kind of these jigs that are kind of pictured here, and devices, we can make it reproducible and reliable, just like a lot of our surgery now. I mean, as you know, in total joint replacement, they use jigs and cutting guides, but also now sometimes robotics to make it more reproducible. And here, we're using jigs and guides. Also, we can also use get the CT scans and do 3D printed custom guides to make it exact guides for correcting deformities in either revision cases or more complex cases. So again, this is an example of a good correction of a bunion. You're able to get those two little sesamoid bones in that one view. You can see those are back to the position they're supposed to be in. The rotation's been corrected, and this joint's been stabilized and is now straight. The bunion's corrected, and that's lasting correction. And this is just an example of some of the equipment that's used to correct it, and an operative picture. And again, the key is these devices that make it reproducible with cutting guides, removing the joint surface of the cartilage, minimal bone loss, and then pushing the bone together, and your body fuses the bones together to make it one bone. And again, that's not a joint where you get any significant motion when walking, so you don't lose anything, but you gain stability and lose the deformity. So this is, again, just an operative picture of how you correct it with these devices. We don't need to labor on that. It's just an idea of how this procedure works. And then it's stabilized with these plates and screws or staple plates. And there's a different, it's been over the last 10 years, it's evolved. There's several companies now have different devices and jigs for doing it reproducibly. And it's been kind of become the standard procedure for certainly any moderate to severe bunion. And again, the key, as I said, is at first you're hesitant about, in the past, it was kind of like, well, you're correcting the bunion. This is a normal joint. Why am I taking away a normal joint and fusing it? But the point is, it's not a normal joint. It's a joint that's malaligned and losing its stability. And so you're improving the function of the feet because you're stabilizing that joint. And I think some people actually get some pain relief, and it stabilizes their arch to some extent, in addition to correcting the deformity. And this is an example of a patient who had the same problem on both feet, had a different procedure where the bone was cut years ago, and made the straight bone crooked. They had some correction, but the deformity persists, and there's still the rotation, versus this procedure where you stabilize this joint, the rotation's correct. And over the years, I mean, they got correction from this because the bone was cut both here and here. They're doing okay, but this may recur. And this is certainly much more an anatomic look, and they think that side feels better. And also, over the years, they may develop arthritis over this side. So the post-op protocol, the Lapidus 3D bunion correction post-op protocol, one of the attractions is that afterwards the bone's very stable. So protocols vary between surgeons, but usually I have patients be partial weight bearing in a boot for the first 2 weeks, and then full weight bearing. They're never in a cast. They're in a soft dressing and a walking boot, and partial weight bearing for the first 2 weeks, and then full weight bearing for 4 weeks, and in a boot for about 6 weeks, sometimes 8 weeks. Nowadays, with most orthopedic surgery, especially extremity surgery, the anesthesiologist does peripheral blocks. That just means they, give you some sedation, put some needles, and block the nerves that go to your foot and ankle. And that way, the worst pain from surgery is blocked. You need less anesthesia. You're asleep for the procedure still, but you need very little anesthesia because your body's not perceiving that pain. And then when you wake up, you don't have the worst pain from the surgery. And for the first 12 to 24 hours, that pain's blocked. And so people, it's always an outpatient procedure. The pain, if you need to, you can take anti-inflammatories or pain pills, but the pain, is usually manageable for most people. And again, the boot for 6 to 8 weeks, and then regular shoes at 6 to 8 weeks, and then full activities at 8 to 10 weeks. So that's the post-op protocol. And I always, in orthopedic, the basic orthopedic principles is, when a bone breaks, you want the bone well aligned. You want to put it back where it belongs. You want a straight bone. And there's some other procedures now. These are some of the what are called the MIS surgery, where you cut the bone, shift it over, try to do it through a small incision. It's perched, the bone's perched on these two little screws. It's very technically, this procedure takes much more time than this procedure. And the thought is, well, maybe the small incision offers an advantage, but it really doesn't offer much an advantage. And this can have a higher rate of recurrence, and it also isn't as stable. And because you still, and again, you still have the pathology here, it may recur. It looks good when you look at the foot visually at first, but I think the recurrence rate is much higher with this versus the Lapidus type procedures, which are anatomic. The foot looks much more normal and anatomic, and in my experience, people do very well with that. And again, an example of a very wide foot, an abnormal foot. That foot's wide, it's painful, it's hard to fit shoe wear. And with this procedure, you can correct really big deformities. I mean, that's why years ago I never really sought out these procedures, and never, they're always difficult because trying to straighten this was difficult. And back then this procedure was more difficult because we didn't have as good of a system and devices. And the other approaches where you try to cut the bone and make the straight bone crooked, make the straight bone crooked to realign it, were hard to fix, and it was just a difficult surgery. But this makes it reproducible to correct really significant bunion deformities. And so again, the beauty of this procedure is that you're fixing the root cause of the bunion. It's a three-dimensional correction. There's no cast. You're walking with your partial weight bearing for the first couple of weeks. Depending on your job, I mean, you can go back and at a desk type job within the first week or two. The key after 80-foot surgery, though, is you need to elevate the foot as much as you can. I mean, but you're not going back to, if you're a nurse, you're not going back to being a nurse in a week and being on your feet all day. So if a job that requires prolonged standing, you'll be off for several weeks till it heals. But certainly certain jobs you can do earlier. But again, the boot's about 6 weeks, and the key is it's designed for permanent correction and a much lower rate of recurrence. So that's a quick overview of bunions and bunion surgery. And I hope it wasn't too technical, but I just wanted to go over that. And again, it's been, I've been doing this for a long time, and it's been one of the more interesting. Again, I never thought I'd be speaking a lot about bunions, but it ends up, it's a very common procedure, and this is one of the more exciting innovations because it solves the cause of the bunion, and patients are very satisfied. I mean, the beauty is that, again, like I said, this is frequently bilateral, and most patients that come that have one side done come back for the second side because they obviously had a good result with the first side. They're happy with it. Their foot feels better. So with that, we can answer questions about this topic or any other foot and ankle topics.
All right, let's start with one question we have up here. Is that
Sure.
if the bunion is not painful, is surgery not then recommended?
Yeah, that's a very good question. Yeah, we don't recommend so-called cosmetic foot surgery. I mean, it's not in some, like for instance, in New York City, there's some surgeons that kind of specialize in cosmetic foot surgeries. Some people say, my second toe's too long. I don't like the way it looks, but we don't recommend cosmetic foot surgery because anytime, all surgeries have risks, and the worst thing you want is pain in your foot if you don't have pain. So we don't recommend cosmetic foot surgery. But that's a good question because the primary reason for surgery is pain relief. So yeah, I mean, if you have a mild bunion, it's not giving you pain. If you wear open shoes most of the time, you don't necessarily need surgery. If the bunion's progressing or starting to rub on the second toe, you want to do something before. If your second toe is starting to ride up, I mean, as the bunion gets worse, the big toe can ride under the second toe can ride up and form a hammer toe. So you don't want it to predispose you to other deformities. But for mild bunions that aren't painful, you don't necessarily need surgery. And it's not, always progressive, especially mild bunions. It's not like, oh, if you don't get it fixed now, it's going to, it's going to look like your mother's horrible foot in 30 years or something like that. So, but certainly if it's progressing, if it's painful, if difficulty with shoe wear causing deformities of other toes, if you're developing calluses and corns and things like that, it can be considered.
A follow-up to that was the same as what about a bunion on the little toe? Is it always on the big toe?
Yeah, that's a good question. By definition, a bunion is hallux valgus, which is a crooked big toe. But there's also what's sometimes called a bunionette, which is a prominence of what's called the lateral eminence. That in some people, your whole foot's wide and instability here. So this is wide. We correct the bunion, but also the wide foot. Sometimes this little eminence here is rubbing. So we do correct bunionettes sometimes. It's a whole different fashion sometimes it's just shaving off the little bump here or the spur. Sometimes we have to also just cut this bone and to realign it to narrow it. But you can have pain and prominence over the fifth metatarsal and have what's called a bunionette. And also, you can also have sometimes, so that's over the metatarsal here, over the toe sometimes, your little toe, if you develop a little flexion contraction of the toe or a hammer toe, sometimes that can rub and, that can be corrected.
Great. Let's jump to in the room here, you gentleman at the front.
Yes. Uh-huh.
If we just, when he asks the question, if you repeat it for the people on Zoom, it'd be great.
Sure. No, the Lapidus procedure requires several incisions. There's one, the major incision is here along the base of the metatarsal, and then there's at least two other small incisions. There's an incision we make between here where we release the ligaments become too tight between here. So with a small incision, kind of release the ligament to allow the toe to rotate. And we have the major incision here, and there's a little small incision here for the fixation device. Depending on the deformity, sometimes we also have to make another incision along the inside of the foot to allow the sesamoids to rotate or to remove any spurs that developed over the years. So it requires usually one major incision and two to three smaller incisions. Yeah, I'll repeat the question. I'm sorry I didn't repeat that first question, but and her question is, if you're diagnosed with bone marrow edema in the first metatarsal, in the other metatarsals. Yeah, if you're diagnosed with bone marrow edema in the other metatarsals, can this procedure correct that? Yeah. Yeah. Yes. Well, it can be. That's a complex question. That's an interesting question and complex question in some ways. Bone marrow edema, what bone marrow edema means, and you only know if you have bone marrow edema if you get an MRI scan. And what it means is fluid in the bone, and that can be from a stress fracture, from inflammation, from things like that. And so the answer is yes, because what bone marrow, for instance, say if you have a significant bunion, you can get bone marrow, you can get stress reactions in the other toes. In fact, sometimes people get stress fractures. The bone actually breaks and from the stress. Sometimes you just get the bunions put more stress on these other bones because your first metatarsal, the big bone's made to take over half the foot weight in walking. But if that metatarsal from the bunion, it's rotated out and not doing its job, these other smaller metatarsals suddenly have to do more work. And so then they develop either bone marrow edema because of the stress, or they sometimes even crack. And so the answer is yes. I mean, by correcting the bunion, you can relieve the stress on these other bones that aren't made to take that much weight and stress. Other questions? Yes. Yes and no. And like I said, the fascinating thing is that. I'm sorry. Yes, his question is this a relatively new procedure? And the answer is equipment and techniques are new, but the procedure has, the fascinating thing is that this procedure was published, I think, in like 1925, a long time ago. But it wasn't, and it really was always the answer. But back then, I don't think it was as well, people, it wasn't as well understood, and it wasn't an easy operation to do and get reproducible. And the problem was when you did freehand techniques, you'd take too much bone, and then it would shorten the metatarsal. And then if you don't realign it properly, you can get these stress fractures in other metatarsals. So you had to be done perfectly, and it just wasn't a reproducible procedure. So the thing is that we really, the other procedures have failed, and then we come to see, well, wait a minute, if we can make this procedure reliable, it is the answer. So, like I said, about 10 years ago, the company kind of came out with these jigs and devices that make it reproducible and reliable, and minimal shortening, and high satisfaction, and resulting in a high satisfaction rate. And other companies have have done the same thing. In fact, that's the sign of success, is that almost every company now has a device that, to do this kind of procedure in different ways. Some are better than others, but it really has been the answer. But yeah, it really shows the evolution, and that from these past, we learned how to do an older operation much better and reliably.
So a follow-up to that question, is the Lapidus 3D option commonly available throughout the U.S.?
Yes, it's pretty available now. I mean, it's obviously at all meetings, people lecture and talk about it. The devices and the different types of fixation are marketed by the companies, so most surgeons are aware of it. Each surgeon has his own preference about what his favorite procedure might be, but it is available throughout the country pretty much. Most surgeons, there's a learning curve, and so we go to meetings, and I've taught some meetings, and with courses and with cadaver labs and things like that to learn the technique, because there's a certain learning curve to it. But yeah, many surgeons have attended those and are trained to do it. Like I said, the other trend, which maybe might have come up in one of the questions, is sometimes people now talk about MIS, or what's called minimally invasive surgery. And that is like I alluded to it briefly, but the thought there is that, okay, well, let's do a small incision, have less pain, it will be faster rehab and things like that. And that's kind of some people, a lot of surgeons may be marketing that, or you may have heard about it, these other techniques, which, like I said, initially they can make the foot look good. They're for lesser deformities, but they're not anatomic, and they've only been around for a few years. And the concern is that there will be a higher rate of recurrence because you're not solving the basic problem. But probably after this Lapidus type procedure, that's the most common procedures being talked about now, is these MIS techniques. And but I don't think the long-term answer is in on those, because it's only been around a few years, and we'll see what the recurrence rate is over the next decade or so.
Great. Back here in the room. Yes, you, ma'am. Yep, you had your.
How many do I perform in a month? Yeah, I probably I'm doing at least 5 to 10 per month now, and I've done well over 300 of these procedures, and one of the highest volume in this. And again, I teach them, so I do quite a few, and again, I've really come to understand and like the procedure because it is so effective.
And what would be the timeline if you wanted both feet done?
I'm sorry, can you repeat that?
Yeah, the question was, what would be the timeline if you want both feet done if you have bunions?
Yeah, that's a good question. And in terms of timing, because it's frequently bilateral, and I usually do not recommend bilateral foot surgery. Occasionally for lesser surgery, say if someone has a neuroma, that's not too bad a rehab. You're full weight bearing. You could do both, or maybe one hammer toe on each foot, or a smaller procedure. But I don't recommend bilateral bunion surgery. Because it's hard being laid up and having, being in two boots and having, you're not in cast, but still you're in two boots. It's hard, being laid up like that. So, but the answer is, I usually recommend about at least 3 months between the surgeries. So at least you're after 8 to 10, after 6 to 8 weeks, you're certainly in regular shoes. Then that one foot's feeling good, and then you can go to the other foot. So about 3 months, a minimum of 3 months between surgeries.
Great. More questions? Yes, go ahead, in the room.
Yeah, that's a good question. It depends on your X-rays and why it's a minimal bunion. I mean, if it's a minimal bunion because of instability here, and if it's the toes moving and it's going to start rubbing on the second toe, you might want to solve the problem here like the lapidus. But if it's just a mild bunion where you just have a bump that really bothers you, and it's not rotating, it's not that this joint's unstable, the intermetatarsal angle's not widened, then sometimes there are lesser procedures that we can do in terms of shaving off the bump, or sometimes still, in that case, sometimes shaving off the bump or cutting the bone here might be enough. Or in some patients, the bunion, they have, the big toe is rubbing on the second toe because this phalanx is actually a little crooked, and we can realign that. So sometimes there's some lesser things we can do. And again, I'm answering the question. I don't know. I think I didn't repeat that one well, but her question was, if you have a minimal bunion, when should you consider surgery, or should you wait? And again, I mean, it just depends how much it bothers you. And some minimal bunions, we can do a lesser procedure that's easier to recover from, or you can, yeah, I mean, there's the lesser procedures, altered or continue kind of following year by year and seeing how you do. But again, it's usually best to wait till you have pain with a bunion, or it's causing problems with shoes or other toes.
Yes, go ahead, in the room.
How long does it take before you, the question is, how long does it take before you can drive? Yeah, well, that's a good question. And the, you have surgery, say if you have your left foot done, if you have your left foot operated on, and then a couple days after surgery, when you're fully recovered, when the block's worn off your right leg, if you're feeling okay with the right side and you're not driving far, and you can drive, but you have a boot on the left foot. Obviously, you have to have an automatic car, and so if you have the surgery done on the left foot, you can drive within a few days. But the key after any foot and ankle surgery is you need to, elevate it, have it for the first few days, especially have it above your heart, keep the swelling down. That avoids any complications or wound healing problems. Yes, if it's your right foot, that's the issue, because you need to be in the boot at least 6 weeks with the right foot, and you cannot drive with a boot, or you should not drive with a boot. Some people try to, but obviously it's dangerous to drive with these big boots. And some people, again, never condone it, but some people try to drive with their left foot. And then, but yeah, if it's your right foot, you have to hopefully have a friend or a partner or someone that can drive for you. But that is an issue. And, and then I always, occasionally we see people that, unfortunately, people have all variations, and then you have the people that drive with both feet. So that's a problem too. But you should never drive with a moon boot, because it's not safe.
You're saying about 8 weeks before you can drive, if it's your right foot?
If it's your right foot, it'd be, well, say you'd be, if, we probably try to get you on the boot at 6 weeks in that case, but yeah, about at least 6 weeks. Yes. Yes, she's asking, is that a boot, a short boot, or a higher boot below the knee? And it is a below the knee boot. Usually it can be a short, it goes halfway up the calf, so a shorter boot, but it is definitely below the knee. And it's a walking cam boot. I mean, you've all seen, they look like moon boots or cam boots. Those are walking boots, yes.
All right. Another question was, if you have another foot issue, say hallux rigidus, does that contribute eventually to like a bunion, or what causes, I guess, is there other ailments of the foot?
Yeah, that's a good question. Hallux rigidus is a whole another issue. And hallux rigidus is really arthritis of the first metatarsal phalangeal joint, the big toe joint, the most common site of arthritis of the foot. And hallux rigidus, I mean, arthritis, and sometimes a bunion, people come in with a bunion, but the toe is very arthritic and crooked. So if the toe is arthritic and crooked, the solution to that is really a fusion of the toe that unfortunately the replacements of the big toe do not work. And the best way to get rid of that pain is to fuse the toe. The toe's already stiff, but we can get rid of the pain by fusing it, and people do very well with that. Sometimes you have to combine it with this Lapidus procedure if the foot's really wide or the metatarsals, the joint's really off. But frequently, if it's a severe bunion with a lot of arthritis, just by fusing that toe, you can get most of the correction. So yes, with hallux rigidus, it is a different approach because you have to fuse that toe, sometimes correct the metatarsal rotation and 3D correction in addition. But definitely a fusion is the key to that.
Great. Other questions in the room?
Yeah. The question is, would you recommend those spacers or pads or things you could buy before surgery? And certainly, obviously, nowadays you can go to the pharmacy or some of these foot stores or even Amazon online. There you can buy a lot of these things. There's little silicone bunion pads, there's toe spacers, there's hammer toe pads, and all those things. Yeah, I mean, I think all those things can be helpful. And obviously, before surgery, conservative treatment is always good for a lot of these problems. And if you can, I would recommend, if you're having pain, you can try these pads to help alleviate some of the discomfort. Sometimes, obviously, the pads are a little bit of a hassle for people. They don't always work. They move around. But if they help you, I certainly would recommend that. But obviously, if it's a bunion problem and it's progressing, and it's painful, you need to consider surgery at some point. But if for whatever reason you need to wait or you can't have surgery or whatever, but these pads are certainly a good conservative treatment for any foot problem.
All right. Additional questions in the room for the doctor?
Yeah, that's a good question. The question is, what is the anesthesia for the surgery? And generally, the anesthesia for the surgery is they do a peripheral block. So before surgery, they give you some of the propofol, the medication you get before a colonoscopy, to sedate you, and they do some needle sticks around, at your knee level, and that gives you a block that lasts for 12 to 24 hours. So the foot's numb, and you don't have any pain after surgery. But also what that does is that requires less anesthetic. So during surgery, you generally have a general anesthetic. So you're asleep for the procedure. When you wake up, you don't have the pain. This is an outpatient surgery, so generally we don't do a spinal for it because sometimes for the total joint surgeries, people have spinals, and the key to that is that's a much bigger surgery, and you're in recovery. Even if you go on the same day, you're still in recovery for hours after that, and it doesn't delay you going home. But this surgery is not as, it's not a major surgery. So the anesthetic you don't need that much general anesthetic. So it's more than just a conscious sedation. You are asleep, but require very little because your foot is not feeling the pain, and you're not remembering or feeling it. And then when you wake up in recovery without the severe pain that you would ordinarily if you've just had surgery. And again, there's some studies that show that when the body blocks that initial pain from an injury, like from an injury or surgery, that you have less pain later. And so that's why people I mean, years ago, people would stay in the hospital overnight for bunions. And as you know, joint replacements, people just stay in the hospital 5 days. Now, most go home the same day. So things have really changed. And part of it's because these anesthetic blocks and improved anesthesia and improved, management after surgery. Another question in the back?
Yeah.
Well, it depends. Yeah, the surgery it takes anywhere from, for a standard one, it takes about an hour for just if you're just doing the lapidus procedure. So I'd say about an hour for the standard lapidus. Frequently, though, for the severe deformities, sometimes you have a severe deformity, you have some spurs here, and sometimes if frequently they're associated with second, third, maybe fourth hammer toes. Sometimes there's people have a pain in the second metatarsal that you described, that bone marrow edema before. We actually sometimes have to shorten the bone to take some pressure off the second metatarsal because that's part of the anatomy that over the years they're just getting too much pressure on that. So sometimes with associated procedures, it could be a couple hours of surgery, but sometimes people have a bunionette. So, but obviously, if we're going to do the surgery, we do it all at once on one foot. But anywhere from 60 minutes, 1 to 2 hours for the surgery, depending on what other things you're doing. But the standard lapidus is an hour or so. And there was another question there.
Back there.
Well, the answer is no. I mean, the answer is generally no, but it depends on what your insurance plan is. Obviously, if I'm at Desert Orthopedic Center. We're a comprehensive orthopedic group with subspecialists in most specialties of orthopedics, and we take most insurances, but it depends on your plan. So if you're in a HMO, we take HMOs, but if you're in an HMO plan, you've got to get a referral from your primary care doctor. Medicare Advantage is essentially a kind of a HMO plan where you do have to get referral if it's Medicare Advantage. Standard Medicare is not a problem. Blue Cross, generally not a problem. But again, there's certain plans in where you have to get referral to see any specialist and for other care.
All right. More questions in the room or online? Anyone? All right. Going once, twice, as they say.
Any other topics or anything? But
Yeah, we have Dr. Friscia for a couple more minutes if you have something else. But so if someone wants to book time with you or to get a consult, how does that happen?
Yes, I'm on campus here at Desert Orthopedic Center. We have a website, desertortho.com. You can nowadays if you're on MyChart, I think you could make appointments actually even through MyChart through Eisenhower. You can call the Eisenhower General number and get referred to our office. Otherwise, we're on campus. Our office numbers is 760-568-2684. But we're on campus here at Eisenhower. I actually only see patients at this site. We have some offsite clinics also, but we have as any of you that have been to the orthopedic center here, we have a great facility here where we have it's pretty self-sufficient, and I think people come from all over the country and love coming here for orthopedic care because we have a musculoskeletal center where almost everything is in one building where you can all our doctors see patients there. There's an MRI scanner there. There's physical therapy there, and we have a 8 OR fully integrated, very high tech outpatient orthopedic surgery center there where we do our cases. So it's a really great facility we have here. If people, for certain cases, we do people can stay overnight for some of the more complex things, or if there's health reasons, but most orthopedic surgery is done as an outpatient, and we have a great facility for that on campus here at Eisenhower.
I have a question.
Yes, go ahead.
So, can you hear me okay?
Yes, we can.
Okay, thank you for taking the time. Hey, I'm a 68-year-old, fairly active male, obviously, and I have a right big toe or the bunion, but the pain's coming from the second, I think you called it a metatarsal. The pain's coming from that second toe in. Can you fix in other words, a hammer toe? Can you fix a hammer toe first, or does it have to always begin with?
Yeah, that's a good question. And your pain's coming from the hammer toe, not necessarily from the bottom of the foot, right? It's from the toe that's sticking up.
Correct.
Yeah. So the issue with that is kind of what came first. So the hammer toes can be hereditary, but if you have a bunion, that bunion's pushing pushing onto that second toe and pushing that toe up and is predisposing you to that hammer toe. So the problem is if, we can certainly fix that hammer toe by taking out that knuckle and straightening the toe, and we'll make it a flat, straight toe. But then the problem is there's not room for that toe because you have that big toe encroaching on it. So then you're not going to be happy because your big toe is going to rub on it either on the side, on the top, or the bottom, or it may cause the hammer toe to come back. So that's why it's best to, you need to straighten the big toe in some way. You may not need depending on what deformity you have, if it's just a mild a bunion, we can maybe just straighten the phalanx and move it away from the second toe. But there's got to be room for the second toe otherwise it will come back.
Okay, thank you for that explanation. Then also, as far as percent of success on a 68-year-old is fairly active, can you kind of throw out there just to kind of spitball what the success rate would be?
Success rate for a bunion surgery or hammer toe surgery, or
for the combined, the bunion and the hammer toe.
Yeah, I mean, I think it's very high. I think it's the success rates in the high 90 percentiles that most people, the toe straightened out, the second toes straightened out, there's less pain. And I think the success rate is very high. There's always with any procedure, there's a chance of complications. Occasionally, whether it might be delayed wound healing, small chance of recurrence. I think so I think the success rate's very high, and 68 nowadays is not that old. I mean, obviously you're all active and hopefully living longer. So I think surgery is more common as we get older. So I think that's not, the age is not a problem. The success rate's high. The hammer toe surgery I think has come a long way also, in that years ago we would remove some bone and put a metal pin through the toe, and you remember people walking around with pins sticking out their toes. It looks it kind of frightening sometimes, but that was the old way of doing it. And then we'd pull out the pin in the office and things like that. That's still done to some extent, but for most deformities, that's not necessary. And what we do now is, again, a whole nother lecture, and technology is straighten out the toes. I mean, correct the cause of it by obviously correcting the bunion or releasing the tight structures. But in removing the bone, now we have some screws and metal devices we can put in. But more importantly, what has been developed lately is absorbable implants, biointegrative implants that I can put in the toe, and that heals and becomes bone. And so this way you don't have metal in your toe, you don't have a foreign object, but you have something to stabilize it that stays there. And and I've had very good success and satisfaction with that in these biointegrative implants for the toes that provides lasting correction, and for the hammer toe deformities, because toes have a lot of forces working on them. And as the questioner was talking about, hammer toes can be very painful where the toes are bent up and rubbing in your shoes. The question is, you had a bunionectomy 10 years ago and a bone spur. Was the bone spur at the time of the bunionectomy or after? When was the bone spur? Yeah, well, yeah, I'm actually have to get extras to look at that, but it depends. Sometimes with a bunion, you have the bunion and you can develop some where the bunion rubs in your shoe sometimes, and the capsule attaches there, you develop spurs. And so that's why sometimes, like with the lapidus, I don't always open that incision, but we have to open it up and remove some spurs. So spurs can be very common around the joint. If you have arthritis, spurs are also common. But if for the bunions, like for the lapidus, if the bunion surgery is done, well, for the most bunion surgeries with good correction, you do not develop spurs later. But if there are spurs present at the time of surgery, we can certainly remove those and correct that, but they shouldn't come back. Yeah, and that may be, yeah, well, the bunions here and the bone spurs here, the bone, there's tarsal joints sometimes develop arthritis and you get spurs over those joints. And generally the spurs it can be early or arthritis that's not always painful, but that's why sometimes the lapidus procedure, if there's any degenerative changes at this joint and spurs, the lapidus procedure corrects that and you never get a spur because there's no arthritis left there. You might have arthritis in these other joints that can affect you that we can have a spur removed, and sometimes we have to fuse these joints too. That's a whole other issue. But the spurs are from a cause and frequently arthritis, and that's what you have or had in that area. And one more. Yeah, the question is, in bunion surgery, do you use robotic? And for bunion surgery, they haven't developed so-called robotic surgery. We do have, patient-specific instrumentation and guides with, we could get 3D CT scans of the foot, and it goes to a company, engineers reproduce a 3D model, and we can get custom cutting guides to make things more precise. But at this point, they haven't developed robotics for bunion surgery.
All right. Well, with that, Dr. Friscia, thank you very much for your time tonight and everyone for joining both online and in person. And just as a reminder, this was recorded, it will be edited, and then it will be put into our, I'll send it out to everyone who registered, but then the link is online for the Eisenhower Health YouTube channel.
Thank you.
With that, be safe out there in our now rain, I guess, a little bit.
Thank you.
Thanks so much.